Good afternoon, everyone. This is Brian Robson, the Executive Clinical Director here at Healthcare Improvement Scotland. Welcome to this, the fourth in our exciting QI Connect WebEx series for 2016. This series came from a request from our national clinical leads here in Healthcare Improvement Scotland to connect frontline clinicians interested in quality improvement with international leaders in the field of improvement. They asked that we make the sessions short, accessible and recorded to allow access at a time that suited them. And as you'll see later on, our QI connectors have expanded beyond clinicians, beyond healthcare and across the world. But before we introduce our QI connectors, I'm going to hand you over to Jennifer. Good afternoon, Jennifer.
Thanks, Brian, and good afternoon, everyone, and welcome to today's session. So I just have a couple of quick housekeeping slides to get started on the use of WebEx. If you could please use the chat function that you see on the right-hand side of your screen, and there's an icon just at the top right-hand side which looks like a speech bubble. If you click on that, and I'll talk you through that in just a moment. If you have any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, if you can just please message the event manager using the chat function or call the number you see on the screen, which is *0. So, these sessions are designed to be a fun, interactive learning experience. So we do encourage you to use the chat function to share any questions, comments or ideas throughout the talk. And there'll be an opportunity for Q&A at the end of the session. So if you want to get involved in the conversation, click on the chat icon circled in red here and select all participants from the drop-down menu, type your message and then send. We'll also be sharing hyperlinks within the chat function to any resources mentioned by Geoff in his session today. So here's the fun interactive part of the session. So we want to hear, we're delighted to have so many countries joining us today, and Brian's going to go on and talk a little bit more about that. We'd like you to tell us where you're joining today's session from. So if you click on the pen icon circled in red above to the top left-hand side of your screen, and then click the arrow icon that you should see, and then click on the map. Welcome to lots of people coming from Scotland, from the north. So welcome everyone. I'm now just going to pass you over to Brian, who's going to just tell us a little bit more about the reach of QI Connect and the organisations and countries joining us today.
Excellent. Thanks very much, Jennifer, and thanks to everyone joining the call from all over the United Kingdom and some folks in Europe as well. It's absolutely wonderful to see that we've now broken through the 400 barrier, so 400 organisations are now signing up and registering with QI Connect. Our reach has really gone from strength to strength. However, as you know, all improvement is good fun, and as part of the fun involved in improvement, we often have a competition, and today is no different. As you know, we have a whole range of countries. Our global reach is more than 40 countries now, and I'm going to name the latest country for you, and the first person to put their arrow on the country flag will get a big prize. So the country we'd like to name for you today is the Falkland Islands. The Falkland Islands. So you need to get your arrow. Hard lines, Fiona. Close but no cigar. Stephen White. Well done, Stephen. And Claire Curtis is in as well. Kerry. Kasia. Excellent. So the Falkland Islands, we're absolutely delighted to have the Falkland Islands join us for the very first time today, bringing our reach up to more than 40 countries, which is absolutely tremendous. And Stephen, you will be the proud recipient of a QI Connect mug in the very near future. Stephen is from Healthcare Improvement Scotland, a Senior Programme Manager here at Healthcare Improvement Scotland. No inside knowledge at all. However, we're absolutely delighted, as always, to shout out some of the organisations. When we started this series, we had one slide with a number of logos on it. we're now absolutely delighted to say that we've got more than 12 slides with logos from all over the world, from the organisations that are linking in regularly with us here in QI Connect at Healthcare Improvement Scotland. We're always delighted to have the NHS in Scotland join, and now all territorial boards in NHS Scotland and many of the special boards across the country are linking in. So delighted to have the whole of NHS Scotland joining us in QI Connect. And as always, we are delighted to shout out the now 36 universities from Dundee to Harvard who are joining QI Connect. We're always delighted to have the students and faculty from these facilities join us and learn together. And a special mention to some of the new organisations that are joining us for the first time today. Aberdeen City Council, Angus Health and Social Care Partnership, the Dublin Midlands Hospital Group, the Peterborough Hospitals, the West of England Academic Health Science Network, and also the King Edward VII Memorial Hospital in the Falkland Islands. So welcome to you, and thanks very much for joining. We hope you enjoy today's session. And as always, our sessions are recorded so that teams can listen and watch from across the world after the event, and we'll tell you in a moment about where you can source all those recordings. So we're absolutely delighted to be able to record these. We have the website with our full back catalogue. This is now session 23 of QI Connect, and all of those WebExes are recorded and available for use afterwards. And as always, we're absolutely delighted to have a partnership arrangement with the International Society for Quality, ISQA, and the QI Connect series is an approved resource within the ISQA Fellowship Programme. Just a shout out to the small but perfectly formed QI Connect team here at Healthcare Improvement Scotland. You've heard from me and from Jennifer, and a shout out to Olivia McDougall, who manages all of the administration and all of the resources as we go through the event, and certification after the event also. And you'll hear later in the call from Joanne Kerins. Joanne is a Clinical Development Fellow at NHS Lothian here in Scotland, working on improving diabetes in Scottish hospitals. And we're absolutely delighted that Joanne will be asking the first question of our speaker later in the call. And remember, please tweet. Twitter has been very helpful to QI Connect, spreading the word and sharing the resources so that we're all learning together. So hashtag HISQI Connect, and please follow us at HISQI Connect. So with all of that under our belts, let's turn to today's speaker. I'm absolutely delighted to have such a brilliant speaker and a brilliant match for our QI Connect theme of innovation and integration. Our speaker today has held various roles in the UK Government, including Director of the Government Strategy Unit, Head of Policy in the Prime Minister's Office, Chief Advisor to Gordon Brown, and in an early stage in his career was a founder and director of the breakthrough think tank DEMOS. Our speaker today is Geoff Mulgan, and Geoff has been the Chief Executive of Nesta since 2011. Nesta is the UK's Innovation Foundation, and Geoff was previously the Chief Executive of the Young Foundation. And you'll hear from Geoff today about the breadth of innovation and integration. So good afternoon, Geoff.
Well, good afternoon, and good afternoon to you all, wherever you may be. What I'm going to do is share some thoughts about how innovation is being run, could be run in the future in health. And I hope some of the ideas I share are useful. And I'd really like feedback after I've spoken about which ones of them might be most useful in solving the problems of future healthcare. I should apologise from the start. I'm sort of half losing my voice and probably need a bit of healthcare myself. But hopefully, I'll manage to get through to 5 o'clock. As Brian said, Nesta is an endowment. We're the National Endowment for Science, Technology and the Arts. We support innovation through quite a lot of different means, sometimes as an investor in companies, sometimes supporting practical projects, including many in the NHS, and sometimes through research. And what may not be obvious is health is probably the most important field of innovation, bar none. About a year ago, we actually polled the British public on what they thought the top priorities were for innovation and innovation spending, and health came way top of the list. And of course, in many countries in the world, health is the biggest sector of the economy. It's 17% of GDP in the US, and almost everyone expects that number to go up. And everyone expects big challenges with aging, etc. So what I'm going to talk about is some of the emerging tools of innovation, and perhaps some of the challenges for healthcare in using them. Hopefully, I now have control over this. Yep, here we go. If you look around the world over the last 100, 120 years, a lot of innovation often took place in venues like these ones you see on the screen. So one is a German chemicals factory, the other is Bell Labs, which gave us things like microprocessors. And a lot of innovation still happens around the world in big centers like this, full of very clever people wearing white coats with a real concentration of science and separate facilities. But one of the things which has really changed in the last 10 or 20 years is the spread, particularly in business, of very different methods of innovation, all of which I think are very relevant to healthcare's future. So innovation driven by users in fields like bicycling or sports. Innovation where the focus is not so much on technology, but how you design services. So things like EasyJet or First Direct in banking. There's open source innovation. Most of the technologies on the internet are not owned by anyone. They're non-proprietary. There's the design-led innovation of Apple. Apple does almost no real R&D, but they're brilliant at making very useful things for customers. There's the spread of open innovation, which I'll talk a bit more about later, where big companies don't assume that they will have the answers within their own organization and try and tap brain power far beyond. More recently, there's been a lot of spread of the maker movement, people returning to almost craft manufacturing, making objects, whether that's furniture or digital technology. And as I'll say, I think there's some relevance to healthcare from that as well. There's a spread of social innovation, which now has funds and teams all over the world. And one of the things, which again I'll say a little bit about later, is challenge-driven innovation, where you focus on a problem which needs solving rather than funneling money through a research team in a university in the classical way. Now, in healthcare, most innovation is still done through fairly familiar methods. A clinical practice being developed in a hospital, new drugs being developed by a pharmaceutical company, new medical technologies being developed and tested. But what I'm interested in is some of these new methods and how they might be better suited to solving some of the big problems which healthcare globally is struggling with, like obesity, or how to cope with dementia, or some of the behavioral issues around public health, which simply haven't been very successfully addressed by the more traditional tools of clinical, pharmaceutical, and other innovation. Now, the framework which we use a lot at Nesta to try and understand what you do and what the options are is summarized by this little spiral, which we've developed to try and describe almost any kind of process of innovation, which will always, to some extent, and I'm sure you'll all have seen this in your own work, you start with some sense of a problem, a challenge, or perhaps an opportunity. You then have to generate ideas. You then try to test them out. You then try and see if they actually work. If they do, you implement them, and potentially you then spread them across a whole health system. And ultimately, you may change the whole system, the way you do things. And at each of these stages, there are different methods to use. So, for example, methods of better understanding new opportunities. For example, what might machine learning computing do for healthcare? there's a fascinating experiment underway in London using blood tests from the big hospitals, which will be applying the very leading edge of artificial intelligence to make sense of patterns, to better predict who may fall sick. Or there's understanding challenges like epidemics like Ebola, or perhaps challenges of worsening mental health. There's then lots of methods for generating ideas, and I'll say a little bit about them. How do you mobilize creativity, whether from your frontline staff or your managers or from patients themselves? Lots of methods then of trying things out through pilots and prototypes and experiments for trying to find out what works, not just what works in health terms, but what's cost effective, what business models may succeed. And then lots of different methods in health systems for trying to encourage the spread of things like that work, like NICE, obviously, in England is one version of that, trying to publicly rule on what are cost-effective and effective health interventions, and hoping that will drive take-up, or maybe you just use commands. And then there's a question of reshaping whole systems, and I will say a little bit about this later. Innovation, really rethinking the whole of healthcare, perhaps with the patient right at the center rather than the hospital at the center or the clinician at the center, or perhaps remobilizing healthcare around patient organizations in a particular disease group. So that's a bit of sort of theory, if you like, and one of the things we would look for in any organization, whether it's a commissioning group or a hospitals group or a part of government, is do you have methods for managing innovation at each of these stages? And they require quite different skills and quite different methods and even quite different cultures of innovation. And that's a sort of process you will see in a big engineering company or a company like Google. Will be following ideas through a spiral not dissimilar to this. In our own work at Nesta, we have a thing called the Health Lab, which we formally launched last year, which is trying to support innovation at every stage of the cycle. So we do a lot of research on future opportunities and challenges. We've run all sorts of ways of generating ideas, pulling in ideas from different sources, pilots and experiments in different places, a lot of work on business models and evidence, a lot of work with patient organizations, scaling different methods, and finally changing whole systems, particularly around collaborative care. Now, I won't talk in any detail about these, but this gives you a flavor of a sort of innovation strategy which tries to be all the way from understanding needs through to large-scale impact. So what I'm going to do is just say a minute or two each on 10 kind of methods, 10 tools for thinking about innovation. And as I talk about each one, I'd ask you to think about whether these might be useful, whether there's a version of them you could be using in your organization. So the first of these is really trying to get a shared view amongst your colleagues or your organization or your stakeholders about what's the direction of change, where is the world heading. In a way, you need that in order to know what kinds of innovation matter most. For example, I mentioned artificial intelligence. You know, where in 5 or 10 years' time will be things like the IBM supercomputer or the Google DeepMind, which is now being used in healthcare, or the Fitbits and sensors which we use. How will they change what's possible? And we've tried commissioning views about what the future might bring. If you're interested, I'd recommend looking at this paper we did last year, looking at the NHS in 15 or so years' time, and trying to describe a plausible picture of how it might work, using new technologies, digital technologies, genomics, and so on, but also a big emphasis on social innovation, patient empowerment, new ways of running things. And a lot of people have found this report helpful for giving a shape to, as it were, the direction of travel, the choices to be made over the next few years. And it's also something to disagree with, because no one quite knows what the future will bring. And we partly wanted to use that to to prompt a really lively debate about what's achievable and how. And we call it people-powered and knowledge-powered. That's where we think the health system is going. But we also point out how difficult it is in practice to realize some of these possibilities in existing institutions. So tool one is really a way of thinking about the future. The second tool I wanted to mention is all the methods of what's called open innovation. And these turn traditional research and development on its head. In the old days, if you wanted to fund health innovation, you would give a large grant to a fantastic team in a big university or perhaps a big company, and that's still the way most funding is deployed. But the open innovation method is almost opposite to that. It says, here's a problem we have, a problem we can't solve, and it tries to find people or organizations anywhere who might have a way of solving that problem. So this is a live example from Nesta, which is the Longitude Prize, which you might have heard of before. We launched this a couple of years ago with the BBC. We actually polled the British public about what they thought the top priority should be for a big innovation prize. They chose antibiotic resistance as the most important problem which needed new creativity. And this is now a £10 million prize fund, but which is open to anyone, anywhere in the world, and of any background to win if they can demonstrate that their solution actually works. And we send our team around the US, India, China, trying to encourage applicants from any source, but what matters is whether their ideas work, not that they have a grand degree from a great university and lots of letters after their name. And there are many prizes of this kind. This is another recent one we've run, which was on new technologies for any housebound disabled people. And here we particularly tried to link up with the maker movement, with people developing often quite simple, quite cheap new ideas, new solutions, because a lot of the history of assistive technology for people in the home has been one of coming up with very expensive, over-engineered and not very practical solutions, which then couldn't be afforded in practice. So if you're interested in that field, look at the website where we show many of the applications. And this was the prize winner a few weeks ago who had a new tool for helping people to communicate without voice. But there were lots of other fantastic solutions there. And we've worked with others like all the Scandinavian countries on similar prizes for disability, trying to tap into new sources of creativity and expertise. And there's a bit of a history of prizes of this kind in healthcare, and I say, always trying to think, where might the best brains be, not just within the NHS or not just within our hospital, but people who may have the brain power, the creativity to solve some of our problems more effectively than we can ourselves. The third sort of theme is one which we've done a lot of work on, and I think will become more and more important in healthcare, which is new innovations which mobilize the public's time and energy. In some ways, this is kind of obvious that almost anything in healthcare you have to work on yourself as a human being, as a patient. You can't expect everything to be done for you by brilliant doctors. You have to look after your diet or your fitness, or manage your own treatment if you have a chronic condition. And we've been doing a lot of work in the last few years on new ways of mobilizing citizen energy, co-creating effective health solutions. And I was going to share a couple of examples. This is one which has been live over the last year in London, which I think is quite exciting. It's one of a family of similar initiatives, and I think Scotland's got one like this too, which recruits members of the public to be trained up in first aid and CPR. They download an app, the Good Sam app, onto their smartphone. And so if someone dials an ambulance, perhaps they've had a cardiac arrest on the streets of Glasgow or Dundee, alongside that message going through to the ambulance service, the message also seeks out a Good Sam volunteer close by in the same cell as the phone of the person making the call, And then, as you can see on that image, on their phone, it will show where the victim is, perhaps where the nearest defibrillator is, if it is a heart attack. And they should then be able to get to that person quicker than even the most efficient ambulance service. And of course, where heart attacks are concerned, every minute you speed up the response can be the difference between life and death. And there's a host of new innovations of this kind which try to really mobilize the public as a new arm of the emergency services, there with some skills, some motivation to help out alongside the professionals, never replacing the professionals, but helping to enhance the quality of the service they can provide. And a very different example is a thing called Shared Lives Plus, which was a response to lots of anxieties people have about elder care and about putting older people into residential homes. The shared lives model, and that there's quite a few variants of this in other countries, essentially adapts fostering, the sort of model used for fostering children, but applying it to the frail elderly or to adults with disabilities. So they move in with a family which provides them care and love and support. That family is paid a certain amount, but it's actually cheaper than putting them into a home. And for tens of thousands of people, this is proving much better in terms of their well-being, feeling part of a community, feeling cared for. And my guess is this will become absolutely mainstream as an alternative either to living in a rather isolated existence on your own, or in sometimes slightly impersonal residential care homes. So that's another innovation which is sort of tapping again public motivation, public energy to be part of the solution, working alongside the formal paid professionals. The next example I want to mention is really the use of human-centered design. Many of you will have heard of design methods. There's lots of different kind of design methods out there, whether for chairs or for things like computing. The main principle of human-centered design is really just always to sort of start with the people and to really observe in detail how they live, how they use services, what they need. So this is just a few pictures from a recent project on pharmacies, trying to rethink how pharmacies could be better organized, more friendly, more usable for the public, and really starting with a blank sheet of paper rather than assuming a pharmacy has to look the way it always looked in the past. This next one is from Singapore, where design methods were really used to completely rethink the whole of a hospital, but tracking the flow through the hospital, what it felt like to be a patient moving between different departments, and using video and photographs and visualization to get deep into the lived experience of healthcare rather than just seeing someone as a condition to be treated. And I think all over the world these design methods are really, they're almost reminding us of our humanity. They're unlocking new ways of thinking about innovation. Now, the fifth theme, in some ways, is quite a complicated one, but I think one which might have big implications for health in the future. And I call this innovation as assembling. So the first example I'll use is one you're pretty familiar with, probably, the iPod. Now, many people think the iPod was invented by Steve Jobs, or someone at Apple had a brilliant idea, sort of a brainwave one day, and out popped an iPod. That's actually completely misleading. If you look at the history of the iPod, what Apple did very cleverly was take lots of other people's ideas, like other people's digital music devices, the Walkman from Japan, German music compression technology. They borrowed from Napster ways of listing music and turned that into iTunes. They developed a whole set of methods of manufacturing, mainly from a company called Foxconn in China, which makes all of the iPods and iPads. And almost nothing in the iPod was actually genuinely original. What they were really good at was taking other people's ideas and putting them together, assembling them in a way that was really, really useful. And I think most of the really valuable health innovations are much less like a new drug or a new device. They're much more like this. They're about pulling things together to be really simple and useful and fit our needs. And I think far too little of this actually happens in healthcare around the world. An even clearer example of this is Google Maps, which I suspect many of you use every day. Now again, Google Maps wasn't in fact really invented by Google. I mean, they had the idea of trying to organize all this geographical information, but because they didn't have the skills within Google, they went out to buy lots of companies which did have skills, one with a scrollable map like this, one with Street View, another one with Google Earth. And they used open APIs to encourage people to develop apps which would use Google Maps. And they encouraged members of the public to fill in bits of the map which were missing. So very much like the iPod, Google Maps is a story much more of assembly, of deliberately bringing together multiple elements in order to be really useful. And my hunch is that in healthcare, a lot of the biggest gains in the next few years will be like this, combining machine and human intelligence to really meet needs. And one of the things actually we've been working on at Nesta in the last 4 or 5 years is a thing called the Health Knowledge Commons, which is a rather long-winded sort of title for trying to apply the sort of Google Maps approach to knowledge about healthcare, to the formal knowledge of NHS evidence or Cochrane collaboration, but also patient-generated knowledge, emergent knowledge, and really trying to answer the question, how do we make that as easy to use, as accessible and comprehensive as something like Google Maps is for traveling from A to B. The next example I'm going to give is about money, and how do you innovate to make money go further and achieve more. We've done quite a lot at Nesta as an investor in companies like this, trying to help them to develop technologies and then grow. But more recently, we've been looking at some of the new innovations in finance around the world, not all of which are straightforward. So there's things like pay-for-success models, where you only pay providers if they actually achieve a health outcome, rather than just paying them for operations or paying them for treatment. You may have heard of social impact bonds, of which there's now about 30 or so in the UK and about the same number in America. And these, again, only pay out money if a provider can demonstrate they've actually solved a problem. One of the social impact bonds we're involved in here at Nesta is one on elderly isolation, which is trying to reduce isolation of older people, partly because there's very clear evidence that has positive effects not just on their mental health, but also their physical health, and the providers will be paid if they can actually demonstrate that's happening. And there's all sorts of new tools for procurement as well. CityMart is another one we're involved in, which works with 50 cities around the world, helping them to buy solutions to problems rather than just buying traffic lights or paper clips or things like that. And this is a field where there's a lot of experiment and innovation going on, most of which will be very relevant to healthcare in the future. A seventh theme, I mentioned at the beginning, systems and thinking about systems. This is very much part of, I think, how the best healthcare managers think. But as you'll all know as well, it's often very hard really to do things in a holistic and systemic way. We've been working in the last 2 or 3 years with some parts of the NHS, really using a set of methods to help, we say, health systems think and act as systems. So, for example, we've taken the problem of reducing unplanned admissions for the frail elderly in particular areas and tried to bring together all the people who have an influence on whether that happens. That's the GPs, the hospitals, the local authorities, the charities, and literally get them in a room and help them to together own the problem of how to improve the quality of life, the health outcomes for the 83-year-old with diabetes and heart conditions and cancers and so on, and stop them going in and out of A&E in often rather miserable ways. And we get the backing from the sort of the system leaders, the people at the top. We try and help them think through options. We try and get them to know each other. The most striking thing we often find is they've never met each other before, the people who are the system, let alone having a shared sense of ownership of the problem. And then they're set quite challenging targets, like reducing the numbers coming to A&E by 20% in a month. And what this leads to is often some quite a radical redesign of the system, how you do assessment, how you do triage, how you run multidisciplinary teams, how you organize data across the system, so you know who this person is who's coming into A&E and what their background is. And we nearly always find the people who are within the system have the ability to solve nearly all of its problems, but they need a bit of a combination of permission and freedom and support and a bit of pressure as well. So we run these in 100-day challenges, which really force the pace, so you have to have actually achieved tangible results within a 100-day period. And I think, methods of this kind are real accelerators of practical innovation. Again, they're not about individual drugs or individual technologies. They're about how these are put together in ways that really work. Actually, perhaps just one other example of thinking systemically is the work of some of the best hospitals around the world. One of the most interesting ones, I think, is in India, the Narayana Hrudaya, the hospital in Bangalore, which has become one of the world's best for child heart surgery, and is done so by adopting a lot of ideas mainly borrowed from Toyota in car manufacturing, but try and think of the whole hospital as a system and try and really reduce any errors or any problems or any defects by getting doctors and nurses systematically addressing the data about what's working and what isn't in a systematic way. So just a couple more to go before opening up. So one of the other themes which we're very involved in at Nesta is how we get evidence used and healthy experiment, not just for sort of testing out, as I say, a new pharmaceutical or a clinical method, but really for every aspect of healthcare. And certainly in England, I think one of the weaknesses of recent years has been a lot of policy in health hasn't really been tested or evidence-based at all. And quite a lot of money, or a huge amount of money and time has been wasted by trying things out which had no evidence behind them. We host a thing called the Alliance for Useful Evidence, which tries to bring together, it's really several thousand people involved in generating evidence, using it, interpreting it, debating when should you use a randomized controlled trial, when can you use natural experiments, how do you make sense of data. And interestingly, some other fields which were far behind health 10 or 15 years ago are now moving forward quite fast. So you'll see on the screen a bit of a web page from the Education Endowment Fund, which is one of the What Works Centre for Schools, which now provides head teachers with access to lots of evidence about what works in the classroom. And as you can see there, it provides them summary information about the cost of different approaches, the strength of evidence, how much impact these have on a child's progression. And if you click further, you can get through to the underlying sort of subtle, complex research. But well over 2/3 of head teachers now use this regularly to keep on top of the evidence about what does and doesn't work. And I think actually now health could learn a bit from these other fields. And from this sort of ladder of evidence, which we use at Nesta, we try to describe any kind of intervention in terms of its strength of evidence. Level 1, you have a clear sort of logic model of why it might work. Level 2, if you've got data which shows it really does work. Level 3, if you've got a control group, and so on. And for service methods and things like elder care, we found this very useful. It's pretty standard for testing of new drugs, but it isn't used in many other fields like public health in a systematic way. Two very final, perhaps more tangential, more lateral things just to share. The first of these is one which we're very interested in, but is still quite small scale, which is trying to apply the ideas of citizen science into healthcare. Many of you will have heard of some of the big experiments mobilizing often hundreds of thousands of people or millions to help on astronomy, tracking stars, or looking at cancer test results and spotting patterns which the professionals just don't have time to do. And there's a big global movement of this kind of large-scale citizen science. We're interested in applying this in healthcare. This is one of the projects we're involved in called Dementia Citizens, which encourages people with dementia or their carers to either use their mobile phone or wearables to gather data and then in time to start running experiments, like experiments with new kinds of diet or use of music with a control group to see what effect they have. There's a similar project underway in Parkinson's, which was on BBC Breakfast TV a couple of weeks ago, which we've also supported. But it's trying to turn patients from being just passive recipients of knowledge and research into generators of knowledge on a large scale. And I think it's quite possible that in a year or two we might see, in fields like dementia or diabetes, tens or hundreds of thousands of people taking part in projects like this and really becoming part of the medical science system. I think it's a very exciting possibility, and I suspect will generate lots of insights which we haven't had from some of the more traditional methods of researching things like dementia. Then the final one is innovation in democracy. What might be some ways of involving the public in decisions about power or about priorities? How do we turn the public services into more of a real conversation with the public? And here I'm going to share a project we've been doing which has nothing to do with healthcare at all, but might well do in the near future. And this is a project called Decent, Technologies for 21st Century Democracy, where we developed some online platforms which, as you can see at the bottom there, allow members of the public to keep notified about decisions being made in a city or in a parliament by a government. You can propose ideas or even draft legislation. You can comment on other people's ideas. You can vote on those ideas, and then you can track the implementation. Now, these are being very successfully used in quite a few cities around Europe. So Helsinki, the capital of Finland, is using this as a matter of course. The newly elected mayors of Barcelona and Madrid in Spain have made the Dissent platform central to how they now will run their cities. Iceland is using them as well. We have a meeting tomorrow in the House of Commons about using them at the level of a national parliament. Now, I don't yet know where these might be used first in healthcare, but I think it's quite possible to imagine in the fairly near future a situation where a city like a Glasgow or an Aberdeen might be trying to involve the public much more in a debate, a deliberation about things like public health priorities. What should you do with licensing laws or fried chicken outlets or bicycle lanes? These are exactly the sort of issues being talked about in places like Helsinki, and maybe they'll be part of helping the public take more ownership of their own healthcare and driving through change. So those are, I say, 10 really families of innovation tools for healthcare, which I don't see as replacing the more classic methods of clinical practice or pharma development or medical instruments, but I think may be able to reach parts the other tools can't reach, and hopefully at least a few of them that might sound like they'd be useful to you. So that's all from me. I'll pass back to Brian.
Thank you very much, Geoff. Wow. What a great series of ideas, and the chat function has been really on fire throughout the whole talk, and I'll come back to that just in a moment. But just before we do that, let's go to our questioner today, our QI connector. Welcome, Joanne.
Hello.
Joanne, you've been listening to Geoff, and you've got a question for him to start the conversation today.
Yes, thank you very much. That was a really inspiring talk. I was wondering if you would have any advice for doctors in training hoping to get involved in or embark upon the process of innovation which you've described, and that becoming a reality that reaches patients.
Wow, well, most doctors in training don't have any spare time, so I'm not sure what to say. But I think a lot of perhaps what underpins many of the things I've talked about is from an early stage, so getting under the skin of patient experience, getting out of the hospital, and it's really seeing healthcare as something which happens in homes, in communities and workplaces, and perhaps just getting involved in one or two projects of that kind in your local community might be a really useful complement to the kinds of things which you have to learn as part of, you know, the everyday medical training. But I suspect you're a much better place to answer your question than I am.
Thank you.
Thanks, Joanne. Do you get an experience in your training to date that innovation is a core part of what you should be doing, Joanne?
Yeah, I think so. I think from my point of view, in the post that I'm in, I do have protected time to think about quality improvement, and that's just been so eye-opening for me, and I think it's really important, and it was touched on a lot in the talk. Even in the, thinking about the NHS in 2030, I think that's something we all need to take responsibility for. And doctors in training are, an excellent resource, I would think, in terms of thinking about, possibilities and ways in which we can improve. So I think, yeah, we need to think about how to tap into that resource and make it more, of an involved process that we can all take part in.
Brilliant. Thanks for that, Joanne. Geoff, we've got a question here, just following on from Joanne's point, from Akin Akinola. Akin's a real QI connector. He is a specialist in surgery in the Golden Jubilee Foundation Hospital in Glasgow. And Akin is really asking, following on from that the best ideas and innovation that actually do work are believed to be abundant at the front line. In healthcare, there seems to be a paucity of ideas coming through. Any clues on how to create a structure or a framework that encourages and supports more people in the front line to actually bring forward and share their ideas?
Yeah, well, I think there are a lot of good examples from healthcare and from business and so on of much more systematically and regularly trying to mine the gold in people's heads of frontline workers, and that can be through explicit programs where you provide small amounts of money or small amounts of time so people can propose ideas, or you may give them a bit of time just to observe how things could be done differently. I mean, to return to Joanne's point, I think it's really important for doctors in training to cultivate the freshness of thinking, which comes from seeing things for new. The longer you've been in any system, the more natural it feels, and you think that's the way things have to be done because that's the way they've always been done. Whereas when you come somewhere new, you can actually much more easily see how things could be done differently. So I think that's part of the great value which young doctors could bring. I think frontline staff have a lot to offer. I think patients do as well. And one of the really interesting things happening around the world is many more patient organizations playing a role in rethinking services from their own perspective, looking at their own experience, and they may have a rather different take from the frontline nurses, doctors, ancillary staff. And then sometimes too, I think it's really important to be open to ideas from completely different fields. I mentioned the hospital in India where they essentially took ideas from car manufacturing. There are some places trying to take ideas from airports, though I have to say most airports have rather long queues, maybe not the ideal to copy. Some of the new digital companies which you use every day, I've mentioned Google, but what might you take from Amazon, which would make healthcare easier to use for the public? So I think the frontline staff are really important, but they're not the only source of ideas, would be all I'd say.
Thanks very much for that, Geoff. We've got a question here from Olivia. Help me out. Who's the question from?
Nelson Kennedy.
Nelson Kennedy, an information specialist from NSS here in Scotland. If you were in charge of health, what would you like to do in your first 100 days in office with regard to innovation?
Oh my God. I mean, well, if I was really in charge, I think one of the things I would slightly shift would be priorities. Because if you look back on the last 50 years, and I'll answer a slightly different question, but it may come to the same answer. You know, what was done wrong in the last 50 years? In a way, we've had massive advances in healthcare, fantastic improvements in treatment and life expectancy and new technologies. But the oddest thing is that we know, and you all know this, that 50% or so of health outcomes are affected by behavioural or environmental conditions more than they are by health treatment, and yet only a tiny fraction of health R&D or health innovation spend has gone to address those environmental and behavioural issues. So things like isolation of the elderly, which I mentioned. So I would, alongside things like the Crick Centre here in London has been opened with a huge investment looking at genomics, which is fantastic, but I'd also try and have an equivalent to the Crick Centre, but looking at what you in Scotland and we call people-powered health, ways of enhancing peer support or community-based healthcare or changing aspects of people's lives to improve health. That is still very much the poor cousin in terms of innovation spending. I'd have much more explicit programs to open up to ideas from the public, from frontline staff, with visible channels to taking them forward. And in a way, I'd go back to the innovation spiral I showed at the beginning, and just be really sure that there are funds and there are teams working at every stage of understanding opportunities and possibilities and taking things all the way through to systems change, and perhaps encouraging towns and cities to be much more explicit laboratories of the future, really trying to cut down on things like childhood obesity or elderly isolation, and say shifting resources a little bit perhaps from the sort of hard technology side of healthcare towards these more human, softer aspects, which probably can deliver more health outcomes per pound spent in the next 5 or 10 years.
Great, Geoff, and that goes very much to getting upstream and the recent public health review here in Scotland, which will encourage us to invest more in innovation further upstream and get wider than healthcare. We've had comments through the chat line, Geoff, about many of the areas that you talked about. People were particularly interested in the spiral, and particularly stage 4 on making the case. So Catherine Patterson, an improvement advisor at the Scottish Government, Kasia, who's a project officer with NHS Dumfries and Galloway's, and Dawn Moss, NHS Borders consultant in vulnerable children, were all making the point that you need to focus on making the case. Dawn does ask the question, or makes the point, that managing the politics with the big P and the small p is important in moving forward with innovation. Do you agree?
Well, first of all, on making the case, I think there has been a bit of an evidence gap on many of the sorts of things which I know you've been focusing in QI Connect. I used to come across this working in national government when we'd look at budgets, and usually the strength of evidence on things like preventive healthcare, public health, was surprisingly weak. And I've seen this again. I've been sitting on an Academy of Medical Sciences review over the last year, and interestingly, if the head of a city council comes in and says to us, okay, I really want to prioritise public health, what should I do? What's the really hard evidence for what will work? The experts don't really have good enough answers. So I think this matters a lot. We've been working on one aspect of this through a project called Realising the Value, working with the Health Foundation and others on much more rigorous analysis of the health and economic benefits of some of the more people-powered health methods, social prescribing and so on. A fair amount of that is already on our website, and I hope would be useful to many of the people here. In the summer, we'll be publishing a lot more of that, really to provide a much more comprehensive set of answers about the impact, the effectiveness of these different tools. I think a lot of politicians want to support these other methods rather than just pumping money into traditional healthcare, just pumping money through hospitals. But I think they've been held back by, say, the lack of sufficient evidence to give them confidence that they shift $1 million, 10 million, 100 million, it really will pay off.
Thanks, Geoff. And Fiona Montgomery, who leads the improvement support team at Scottish Government, is highlighting that getting a culture of innovation and getting a culture of continuous improvement, are they the same thing or different?
I think they overlap, but they are different. So, I mean, you can endlessly sort of spend time trying to define exactly what is improvement, exactly what is innovation. I think to have a constant culture of improvement is absolutely essential for any organisation. And the Bangalore hospital I mentioned, to me, is a kind of model of that, where all the people involved in daily practice every week look at what's working, what isn't working, what the data says, what the feedback from patients is, and then together discuss how they could make things better. They don't wait for a policymaker to do it or a manager. It's embedded in day-to-day practice that you're always learning, always improving, and always in a way focusing on the things which don't work in order to fix things. Now, often that does generate new innovations, but some innovation goes much further than that and is by its nature dramatically more radical. So something like the Good Sam app, which I showed earlier, that's not going to come out of an out of an improvement process. That's really a completely different way of thinking about how an ambulance service might work. What are the untapped resources in the community which could be mobilized? And if you think of, your local bookshop probably would never have dreamed up an idea like Amazon as a way of selling books. So there's a kind of continuum from everyday improvement through incremental innovation to really radical innovation, and each of them requires slightly different methods to bring new ideas to life.
Well, wonderful, Geoff. The chat box has been, as I say, on fire throughout the whole talk. Unfortunately, we've come to the end of our time together today. I'd like to thank you, Geoff, on behalf of QI Connect and all the QI connectors across the globe. I'd like to thank all of the chat participants, and I'm sorry we didn't get to all of the questions, but thank you very much. I hope it's been very helpful. Thanks to Jennifer and others and QI connectors who've been filling the chat box with additional resources. So, Geoff, thank you very much indeed. Wonderful talk and a wonderful contribution to QI Connect.
Thank you all very much.
I'd like to shout out the next speaker in our QI Connect series, Maxine Power. Maxine is the Director of Innovation and Improvement Science at Salford, where she leads the Innovation Centre, HALO. A clinical speech and language therapist by background. Maxine will join us on the 26th of May. Absolutely delighted that she can do that. And just to remind you of the amazing blow your socks off lineup for the QI Connect for 2016. Difficult to believe we're almost halfway through the first 6 months. But all those resources, all of the talks, all of that is on our QI Connect website. And so it just remains for me to thank everyone, to remind everyone to go onto Twitter to access the resources, and thank you all very much indeed. Have a good day.